Welcome everyone to our monthly biostatistics seminar. I'm Rebecca Batensky, the chair of the Biostatistics department. And I am very pleased to introduce our speaker today, Professor Sherri Rose. Sherri Rose is an associate professor at Stanford University in the Center for Health Policy and Center for Primary Care and Outcomes Research. She is also co-director of the Health Policy Data Science Lab. Her research is centered on developing and integrating innovative statistical machine learning approaches to improve human health. So I've known Sherri for a long time when we were both at Harvard together, and in particular worked together on various diversity programs about which she is passionate, as am I. So it's wonderful to welcome you here, and thank you very much. So please go ahead.
Thank you, Rebecca, for the lovely introduction and the invitation to speak to you today. I'm delighted. I'm going to go ahead and do that wonderful vamping while I bring out my slides. I'm delighted to be talking today about machine learning in healthcare, which my subtitle, Too Important to be a Toy Problem. Hopefully this will be pretty transparent to you why I feel this way, and hopefully I can be convincing such that you also feel this way. I'm going to offer perspectives on challenges for data science and healthcare, and in particular, I'll be centering avoiding perpetuating harms to marginalized groups. And this is one of many reasons why real health data is too important to be a toy problem. For example, as a quote unquote example in a stats paper that hasn't been genuinely engaged with. So my research, my applied research intersects with health economics and health outcomes such that they can influence, hopefully either immediately or down the line, health policy. And when we think about machine learning in healthcare, this is a perspective that's not always seen. There's very few people who are working on machine learning and health economics. And I'm glad to be trying to contribute at this interface such that we can try to be really thoughtful about the types of methodologies that we develop that could, again, have an impact on real human lives. So when I think about the statistical methods that I develop in my training as a statistician, we have data and knowledge as inputs into a machine learning system. But a key thing is that we have a priori specified benchmarks. Under the hood is a grounding in methodological theory, but it's flexible enough to handle the real data that we have. So if something is theoretically optimal, but it won't be computationally feasible or useful or translatable in practice, that's something that's usually not going to be able to solve a problem that I'm trying to solve. So I like to lead my talks with a few quotes that get at different angles of the considerations we're thinking about in machine learning for healthcare. The first one, learning two fields takes surprisingly twice as long as learning one, but it's worth the investment because you get to solve real problems for the first time. I'm a big believer in being dual trained. That doesn't mean that you have to get a PhD or a PhD at all, but a PhD in an interdisciplinary field. But investing in learning in if your training is in statistics, investing in learning the applied area in a deep way, such that you can genuinely understand those problems, you'll really be able to contribute in ways that you cannot contribute if you don't do that. And one of the fields that's really done a lot of this in statistics is genetics and genomics. We have fewer people who are that invested in the real problems in healthcare. It's very much, what are the X's or the Y's? I want to throw my machine learning tool at it and have it as an example in my paper. And in order to really advance healthcare, you need to engage at a deeper level than that. And similarly, people who are clinically trained, it can be quite dangerous to take a machine learning algorithm off the shelf and throw it at a problem without understanding that machine learning algorithm in a much deeper way. So the second quote from Rediet Abebe, in both private enterprise and the public sector, research must be reflective of the society that we're serving. When we have homogenous teams, this is bad for a lot of reasons. We're going to overlook important aspects of the research. This can include what the research question itself is, but it can also include how we evaluate the tools that we develop and many other aspects of the pipeline that I'll talk about in this presentation today. And then lastly, a quote from a book by Nick Jewell, behind every data point, there is a human story, there is a family, and there's suffering. This was a book that I read the first year of grad school, and Nick was one of my professors. It was something that that immediately hit me, and I think about it a lot, even though it's been a long time since I was in grad school. We really do have to respect that these so-called rows of data are people, that they aren't there for careerism, they're not there for us to write papers that get published and then, that data to not have an impact. So I just encourage people to think about that. So since I just spoke about data, I'm going to have a short section where we talk a little bit more about healthcare data. And this is a slide I've had in my presentations for over a decade now. The increasing availability of electronic health information offers a resource to health researchers. I used to say that the general usefulness of this type of data to answer targeted scientific research questions is an open question, but now I think it's generous to cross that out and say that it varies. Again, generous because sometimes a data source may not be useful for the research question we're trying to answer at all. And I believe a large number of us are statisticians. We may need novel statistical methods that have desirable properties, again, while remaining computationally feasible. But I'd like to articulate, as much as I enjoy developing new statistical methods, again, the data itself, the quality of the data, thinking about the inherent biases of the data, that component of it can be so much more important than the methodology component when you're trying to solve real problems. So understanding whether that's the right data for the research question and whether you can actually surmount some of the challenges of that data type is something we need to be really thoughtful about. So I have the title of this slide, EHR does not equal EHR. So electronic health records are that the EHR abbreviation is used very generously to describe many forms of data. What we would generally think of EHR data as are this clinical records bucket. But a recent review found that most of the papers that talk about EHR data are actually talking about billing claims. And I think that's an important distinction because billing claims data, as some of you are familiar, billing claims data is not collected for the purposes of research. Many of these data forms are not, but billing claims is not collected to be clinically informative. It's collected for the purposes of billing. And we have very large sample sizes, but we lack a lot of important clinical information in that data. Whereas with clinical record data, we do have this clinical information, but these clinical record systems are not integrated across different systems. Another common form of healthcare data are clinical registries, where we have really disease-specific clinical information that can be incredibly useful, but we may only have short-term outcomes. Now, that said, we can sometimes link to vital statistics and get longer-term outcomes. Survey data is another bucket of data where we might have tailored our survey to answer a very specific research question, but as we know from the survey literature, we will typically have much smaller sample sizes here and face challenges like recall bias. The last bucket that I have that's light blue, and with light blue indicating some of the more common data sources, are these government data sources. Now, these buckets are not mutually exclusive, and some of these data sources could fit into more than one bucket. But what I'm referring to here as government data sources often include unique information that's not available in other data sources, but it's typically not at the individual level. And so we may be able to bring this into our data at the zip code level or another higher aggregated level. But we need to be very clear here, as with many of these data sources, probably most or all of these data sources, that there are inherent biases in government data sources. So one example is if we were to bring in crime statistics, we need to understand the societal bias that's built into those crime statistics. Three of the newer buckets of data that I have here, wearable and implantable technology, digital data, news media data. So wearable and implantable technology is an exciting area where we can have really granular information on, let's say leisure time physical activity in a particular population. And we won't face the challenges of recall bias, but we may face other challenges of measurement error where an accelerometer like a Fitbit may be good at measuring steps, but bad at measuring distance. Again, we also need to think about the population that's going to have a Fitbit available to them. And with digital forms of data, like search data or Twitter data, this data can be noisy, and it's important to be skeptical of this data source and all data sources. But we shouldn't dismiss it out of hand just because it's a newer data source, because we can get information here that's not available elsewhere, especially in regions that don't have high quality healthcare. So when we think about billing claims or clinical records and want that to be a particular quote unquote gold standard, which it is not, we do need to think about how somebody needs to have an encounter with the healthcare system in order to even appear in that data source. And there are people that do not have an encounter with the healthcare system, and they may be in a digital form of data. Now, you may have noticed that there's a dark blue imaging bucket in the clinical records blue bucket. This imaging bucket, so when we have MRIs, this is often integrated into a clinical record system, but we could also classify this as digital forms of data. Again, these buckets are porous. Lastly, news media data is a crucial form of data for outbreak detection, and it is usually much more reliable and timely than using some other form of data that would have long lags when we would have access to the data. And this news media data has become even more notable as far as our current pandemic. And related to that, I recently, with an infectious disease expert colleague of mine who's a former trainee, Maya Majumder, we wrote a piece a few months ago about healthcare claims data and COVID-19 research, because one of the things that we had seen are people, again, who don't understand the limitations of billing claims data, using it for things that it's not going to be reliable for. So for example, a lot of types of causal inference questions are going to be very challenging or impossible with billing claims data. And even if you're well-intentioned trying to work on COVID-19 research in the pandemic, billing claims is often not going to be the right source. And there's very specific types of questions you might be able to answer with billing claims, but often not causal inference, again, as one example. So the next section I wanted to discuss is generalizability. And a lot of times when we are talking about generalizability, we're focused on inference. But I do want to stress that generalizability applies to other research questions like prediction and clustering, and I'll get to those in a moment. When we're thinking about inference, we might want to generalize from a randomized trial to a target population, or an observational study to a target population. Or sometimes we might be interested in transporting an effect from one of those studies to a different target population. If I'm studying Medicaid in New York and I want to know if that effect transports to another state like Texas, where the Medicaid population is very different and other aspects of the population are different, is that possible for us to do? And I've been working on a number of really exciting projects with some current and former trainees. Irina Degtiar is a PhD student in biostatistics at Harvard, and Austin Denta is now an assistant professor of economics at Tulane, but he was my postdoc when I was at Harvard. And so I'm looking forward to sharing their work in this space, bringing machine learning approaches to generalizability for many of these questions. But I did mention that I was going to talk about prediction and clustering, and this is one of my soapboxes that I get on a lot, is the easiest way to bring machine learning to healthcare research is to take, again, an existing tool and throw it at a problem. And most of these are prediction problems. And I'm very concerned about the rigor and robustness of a lot of this type of research. We see a lot of papers where a team might take 1 year of data in a particular center, throw a prediction algorithm where they're trying to predict maybe a binary outcome, some type of health outcome, and they don't have an external sample. They use very limited metrics, and in order to evaluate that algorithm, the so-called AUC leaderboard is very common, where you just rank by a single global metric. And this can really hide a lot of problems in the data. And I see this very commonly, again, in the clinical literature, but also in other literatures, in the health policy literature. And now it's starting to come into the econ literature a bit more. And a few years ago, I wrote a piece about this where I highlight some of these issues, where we need to have higher standards. We need to expect that there's an external sample. So not just internal cross-validation, but we need to have external samples. We need to be thinking about generalizability for our algorithms, again, when they're in healthcare, we should have incredibly high standards if we're saying something's ready to be deployed in practice. And there's many papers that are being published that I would probably classify as a pilot study at best. And the authors make claims about how this should be used everywhere for this patient population. And it just completely lacks the evidence that that's the case. Another point, harkening back to a quote from earlier in the talk, I stress again that the machine learning researchers who develop algorithms for prediction and the clinical teams interested in implementing them are frequently and unfortunately two non-intersecting groups. We really do need to have, again, people who are dual trained, but we also do need to have better team science in this space. So it's not enough, again, to meet with someone and say, can I have your data? What are the X's, what are the Y's? We need really engaged teams that are developing the research questions together, developing the algorithms together such that they'll actually be useful in practice. So another area that we need to think about in healthcare data is data set shift, where we have the input data changing by the time the algorithm would be deployed. And I've now said many times that billing claims data has a lot of problems. Well, data set shift is something we need to think about in billing claims. And this can happen, the data itself can be changing year to year, even if the population itself is not changing. Well, how does that happen? Coding practices are very unreliable. So here I have a graphic that demonstrates in a particular year, individuals who were coded for these specific chronic conditions, what % of them were coded for that same chronic condition in the following year, so in year T+1. And you'll see that there's a wide variety of percentages here about how persistently chronic conditions are coded. And we would expect that, or we would want that chronic conditions would largely be persistently coded. So individuals with type 1 diabetes are reasonably persistently coded. There's many reasons why we might be missing a code for any of these conditions and why we might have misclassification in disease status. But one reason why we do see a high amount of coding for diabetes is because they are having regular, many diabetes patients are having regular encounters with the healthcare system. But if you look at individuals who had a code for paraplegia in that first year, less than 60% of them were coded for paraplegia in the subsequent year. So again, somebody having a code may not mean that they actually have a condition, but here you see the absence of a code does not mean that they don't have that condition. And this becomes even more difficult to study when people have multiple chronic conditions, especially among older adults. So the next section I call familiar questions, different problems. So for the statisticians, these statistical questions will be familiar, but the applied problems will be potentially ones you haven't worked on, but they'll be familiar. So a lot of my work has been in the area of planned payment risk adjustment in the healthcare system, where we aim to redistribute funds based on health. And the idea is to encourage competition among insurers based on efficiency and quality, not them avoiding high cost enrollees. And this has massive implications, financial implications. If we think about an average enrollee might cost around $6,000. With over 50 million people in the United States currently enrolled in an insurance program that uses risk adjustment, this is hundreds of billions of dollars. Now, how this will look familiar to you is that risk adjustment is a prediction problem. We have a spending outcome, we have an input vector of documented sex and age categories, and then usually we have a lot of binary flags for different health conditions, again, from billing claims. And then we have a coefficient vector that in risk adjustment is often called the weights, but this coefficient vector is across all of the health conditions and documented sex and age categories that are included in the risk adjustment formula. Now, the massive size of the healthcare sector makes risk adjustment arguably one of the most consequential applications of regression for social policy. And when I first started working on risk adjustment in 2013-ish, one of the first things I learned about was the issue of upcoding. And this seemed like a pretty overwhelming challenge. So I left the formula on the screen here because it may be intuitive to you that insurers will be incentivized for individuals to have as many codes as possible, because if they are coded for a particular condition, that they're going to have a positive weight on that condition, which is going to increase the payments to that insurer. So this incentive to have individuals coded for as many conditions as possible can create this incentive for what is called upcoding. And there are legal and illegal forms of upcoding. And I started thinking about, are there ways that we could bring different statistical learning methods to this problem to try and disincentivize upcoding? And so I was a little worried about this challenge. I didn't know where to start, but then I thought, I do know some statistics. And again, I'm one of very few statisticians working in the health econ space. And so I thought there might have been some things that haven't been tried yet where I can try and begin to attack this problem. I'm not saying I can parachute in and solve it immediately. Obviously I haven't, because I've been working in the area for 8 years. But so one of the first things I tried was, what happens if we reduce the set of variables that is included in the risk adjustment formula? So rather than having dozens and dozens of variables, what would happen? Again, this was very much a pilot study. I pitched it as a pilot study because we would want to understand any negative ramifications of reducing the number of variables. But what was really surprising is that using data adaptive machine learning tools, reducing a set of risk adjusters in that formula to this set of 10 variables was 92% as efficient in this commercially enrolled population, the same commercially enrolled population data that is used to create the risk adjustment formulas for the health insurance marketplaces. So this was surprising. And in this 2016 paper, I noted that replication studies in other populations, including Medicare, are ongoing. But since it's now 2021, I can tell you that that replication study has already happened. And I've crossed out my result because this did not generalize to a Medicare population. So results for the risk adjustment algorithms that considered a limited subset of variables performed consistently worse across all benchmarks. And so I want to be really clear that not only did the variables that we isolated in the commercially insured population, not only were those variables not the right variables to reduce the number of variables in the Medicare formula, but even the process, even the algorithm, even fitting the data on the Medicare sample data that we had and rebuilding an algorithm that used a subset of that data, so specific to Medicare, did not generalize. And that's something that's surprising to people because they often think, even if the fixed formula doesn't generalize, shouldn't the process generalize? And it did not here. And I specifically think that this is an important example because we often exclude individuals who are older adults in many of our studies that we do. And so the fact that I studied this specifically in Medicare, which is a population of individuals who are over the age of 65 and people under the age of 65 who have disabilities or end-stage renal disease, that this is just a window into the idea that, again, you need to think about who's in your sample and then who's the target population that you want to generalize to. And then lastly, in this section, I also have prediction using the wrong data. So I mentioned that we use commercial data to build risk adjustment formulas in the health insurance marketplaces. These are two non-overlapping groups. If you have insurance through your employer, you are not eligible to buy insurance on the health insurance marketplaces. And then we also see this in Medicare, where traditional Medicare data is used to build risk adjustment formulas in Medicare Advantage, which is a managed care plan. And what was interesting in these studies, here I created matched samples that tried to create new samples that looked more like the population where the risk adjustment formula would actually be used. So trying to, again, develop a sample that could be used for prediction where we might not have as much bias because we're using the wrong data. And what I found was that the results were very, very similar. And this was unexpected. It was unexpected that using the wrong data actually did not seem to be a problem in these two cases. Now, this is just, these are just two pieces of empirical evidence and something that we need to continue to study because we do know that the Medicare Advantage population is very different than traditional Medicare, likewise with the marketplaces. In Medicare Advantage, we know that individuals are younger and healthier, but as more people are enrolling in Medicare Advantage, we know that that population is also including a larger number of medically complex individuals. So this may not be something that holds over time. The next section that I'll be discussing is fairness. And this is a really broad category of topics. Like generalizability, it crosses many different types of research questions, including inference, clustering, and prediction. Again, it's incredibly broad. I'm just including a few things that we might think about when we're talking about algorithmic fairness. So who decides the research question? Who is in the target population? What do the data reflect? Again, we know that our data reflect issues like structural racism and issues of access in rural communities and low SES communities. And then how will the algorithm be assessed? A lot of work has been done in the how will the algorithm be assessed space, particularly in computer science. Now, we know that our technologies that we develop in healthcare and elsewhere do not have the same performance in all groups of people. And there's a well-known paper called Gender Shades that demonstrates substantially poorer classification accuracy for facial recognition technology for women, and especially among women who have darker skin tones. And this was, a groundbreaking paper that there were companies that responded to it. IBM responded to this paper in order to try and improve the performance of their technology. And we see issues like this in healthcare as well. But aside from technology, I also wanted to highlight that how we design our studies can also be incredibly problematic. Who is and isn't being studied. This is a ProPublica analysis from 2018, where they found that Black individuals and Native Americans were underrepresented in cancer clinical trials, even when the type of cancer being studied disproportionately impacted those racial and ethnic groups. And so who isn't being studied is something we need to think about, especially when we center randomized trials as being primary, as being the gold standard. There are so many randomized trials that exclude different types of populations. And this is also happening during the pandemic. We also know this is an issue for older adults. So there was a recent example that I have here on the screen from September, where this study found that older adults are likely to be excluded from more than 20% of COVID-19 clinical trials and 100% of vaccine trials. And we have, 9% of the population in the United States are individuals who are over the age of 65. And we have 30 to 40% of the cases among this group and 80% or more of the deaths. So the fact that they're excluded from trials is, again, something that we need to be thinking really critically about. When we start talking about algorithms for fairness, we could break down some of the methods into three bins that I have here. So the pre-processing stage, where we might try to debias the data, the fitting stage where we're building algorithms, and then post-processing after the algorithm is being deployed. So how do we develop tools after we have an algorithm that may be biased? So in pre-processing, we consider things like data transformations, where again, we're trying to intervene on the data in order to try and remove societal bias. The fitting phase includes a lot of work. The vast majority of the work is in the fitting phase, where this can include things like adding variables, having separate formulas for different groups, and then different types of statistical learning algorithms. And I'll talk more about some specific forms of these in a moment. But I do want to stress that a lot of people, their instinct is that adding variables is something that can really help remove bias. And oftentimes that's not the solution, because it's just going to create a feedback loop where you're actually building bias back into the algorithm. And then lastly, in post-processing, you can have different thresholds for a classification problem. You can have different thresholds for different groups as far as when it's toggled 0 or 1. So to be a little bit more formal, in algorithmic fairness, we may have an outcome Y and a vector X that includes a protected class or sensitive attribute. So this could be a class that's protected legally, or it could be another group that may be defined by some other type of feature. So in healthcare, this could include individuals who have particular types of health conditions. The goal, again, a lot of this work is in prediction. So the goal is often to create an estimator for a function of X equals Y, while ensuring that that function is fair for A. And many common measures of fairness are based on the notion of so-called group fairness, where we strive for similarity in predicted outcomes or errors for groups. So here's a figure to help visualize this. If our sample is everyone included in this rectangle, individuals who are in a particular group in this yellow rectangle, we can calculate fairness metrics among those individuals in the yellow rectangle. And then we can also calculate that same fairness metric in the complement in everyone who's not in the yellow rectangle. So in risk adjustment, to bring you back to that example where we're setting health plan payment, we may be interested in a metric called net compensation, where we take the difference between your predicted spending and your observed spending. So if that number is negative, if your predicted spending minus your observed spending is negative, that means that the insurer is going to be undercompensated for you. And if we were to average over everyone in the yellow rectangle, if the average net compensation in the yellow rectangle is negative, that means the insurer now has an incentive that they don't want to cover people who are part of that group because on average, they're being undercompensated. And we know that plans have ways to discriminate against groups, and I'll come back to that. But this is particularly salient for risk adjustment and mental health. We know that changes in financing and the organization of mental health care, not new treatment technologies, made the difference in improving mental health care from 1950 to 2000. I have a quote here from the book Better But Not Well. Improvements evolved through more money, greater consumer choice, and the increased competition among providers that these forces unleashed. So it's not only that new treatments are important for us to think about, but financing is incredibly important. And how we manage the financing of mental health has major implications for overall health in the United States, where 1 in 5 people have a mental health condition, and mental health costs overall are substantial. We know that mental health conditions are #1 in total costs. We also know that they're #2 in spending growth. So again, how does this impact risk adjustment? In one of our other studies, we found that risk adjustment in the marketplaces recognizes only 20% of enrollees with mental health and substance use disorders. So not only is this a group of individuals who have higher costs overall, but the risk adjustment formula does not recognize the vast majority of them. So this means that individuals with mental health and substance use disorders can be systematically discriminated against. The insurers are going to be incentivized due to these high costs and this undercompensation that I talked about. And so what can they do? They can change the benefit design of their health plans. They can put drugs in higher tiers. They can change their provider networks such that people with these health conditions are less likely to enroll in their plans. One of the other areas that I mentioned that you can try and improve these issues of fairness is by building new algorithms themselves. And so this is one area that I've worked in. This was a paper co-authored with a PhD student, Anna Zink. And we developed new constrained and penalized regressions that would build fairness constraints directly into the loss function. And so here you can see for a number of methods, the R-squared values. And for those of you unfamiliar with risk adjustment, which may be most or all of you, these are very typical values of R-squared. So 12.9 to 12.4. The key thing is that the R-squared values are very similar to each other. There's only, we only see a 4% drop from standard practice, which is ordinarily squares, compared to some of these fair regression methods. And our 2 new methods are here in this red color. But when we look at this net compensation metric, what we saw was a massive improvement in fairness. So we went from being nearly $2,000 undercompensated to almost zero, so only $46. And this, this $1,872 of undercompensation represented 16% of mean spending. So this is a very substantial amount of undercompensation. And so an existing method and one of our new methods had the best performance in this data analysis. But this paper, which is open access in biometrics, if you're interested in looking into our simulation studies, we included those as well. We found that it was actually the net compensation method that is listed here as performing the next best after those 2, that performs the best across a variety of scenarios, including complex model misspecification. And our code is also available on GitHub if you're interested in learning more about implementing these types of techniques. And one of the things that's exciting is I mentioned that sometimes the work in working in health econ and health outcomes, you can have a direct impact or you can have an impact over time. And I've had both experiences, but this work in fairness is one of those areas where I've been working on it for a long time, because we want to make sure, again, that, you know, for example, if I improve fairness for mental health and substance use disorders, I want to make sure that that doesn't harm other groups, that we're not, you know, benefiting one marginalized group at the expense of another. And we have a paper that is available as an NBR working paper that just went back to a health econ journal, where we had some really exciting results, where we brought together a lot of the things that I've talked about today, bringing together the variable selection and bringing together the fairness metrics and some other techniques in post-processing that I didn't discuss today. But we found that one of the amazing results in that paper is that by improving fairness for 4 chronic condition groups, so 4 groups, including 4 of those groups in the loss function, that we improved fairness for, you know, a large percentage of other groups that weren't included in the loss function. So nearly 90% of other groups that we examined. And what happens is that by improving fairness for those groups, we're not taking money away from undercompensated groups. It's coming from individuals who are already overcompensated. It's coming from individuals who do not have any recorded health conditions. So individuals who had no conditions were overcompensated by over $2,200, and that went down to about $800. So just to give you an example, you know, I have a lot of people that often ask me, what's the way to have impact in health policy? And bringing all of your methodological advances into a paper where you can start giving practical recommendations, again, in a careful, thoughtful way, is how you do that, and bringing that work to the right people, to the right policymakers. And so I find that a very exciting aspect of being a statistician in the health policy space. I wanted to close this section by highlighting a recent review article I wrote with a brilliant team of women on ethical machine learning in healthcare. And in this paper, not only do we review a lot of the papers that have been written in this space, but we also propose an ethical pipeline for machine learning in healthcare. And obviously, given this talk, this is something I'm pretty passionate about. It starts again all the way at problem selection and how we decide what questions we're going to ask, who gets funding. We have disparities in funding that we know for Black and African American individuals in the United States from NIH. And then all the way through post-deployment considerations, you know, what happens after we build this algorithm. And the last section I'm going to talk about is policy and practice. So again, I get a lot of questions about influencing policy. And this will also be a question that's a causal inference question. People are often interested, when can I do causal inference and use some of these, you know, these much more complex methods, and when does it matter? When should I invest in learning them and applying them? Because they're, you know, it's a hurdle to both develop them or apply the ones that already exist and then explain them to stakeholders. So as a teaser, this is an example where using more complex methods and the additional robustness that they provided was very important. So I have some headlines about medical devices here on these slides, where many of them are around the idea that an implantable medical device could kill you. And while these are sensational headlines, they're in many ways valid, because medical devices can kill you, even for some devices where that is rare. Other devices it is less rare. And one of the problems we have is that a national medical device system has been proposed, but does not exist the same way it does for prescription drugs. So information to distinguish individual devices is not currently routinely collected, and it's not available in medical claims. As it is for prescription drugs. And again, this is important because these devices are high-risk devices that are studied in small trials. They change over time, and they can have really severe side effects, including death. And we also know that, you know, because they're evaluated in the pre-market setting, that studying them in the post-market setting is also incredibly important. And one of the areas that we were interested in studying were in a percutaneous coronary intervention cohort. We wanted to understand the potential heterogeneous effects of different types of stents. Now, there are 2 major types of cardiac stents, bare metal, and drug-eluting stents. And drug-eluting stents are coated in a time-release drug to prohibit cell proliferation. And so the bare metal stents do not have this drug coating. And usually in studies, bare metal and drug-eluting stents are compared to each other. But we were interested in, again, what about the different types of drug-eluting stents? This is a large class of stents, and do they have different impacts for a safety outcome? And what we found was that they did. And so there were, again, so here, smaller numbers are better. Having fewer safety outcomes is better. We saw that there were a number of stents that had below average a number of safety outcomes, and then we had some that had extremely high. So the range is from, about 5% up to 25%, which is a massive difference when you're thinking about a stent that has a 1 in 4 chance of having a safety outcome. The stents here are anonymized, where the manufacturer is given by the letter. So you may also notice that the best performing stent and the worst performing stent are made by the same manufacturer. And one of the things that we originally studied is we thought, oh, instead of looking at these individual stents, what if we studied stents by manufacturer? And we quickly realized that both scientifically and biologically, this is not something that we wanted to study. We actually wanted to look at them individually. And it's good that we decided to do that, because again, even looking at them by manufacturer would have hidden this heterogeneity. And there's a lot of reasons why we can have stents from the same manufacturer have such disparate performance. So from stents C1 and C3, they were approved 4 years apart. So 4 years is a long time in the device world. And they also have different polymers and different stent delivery systems. So this was not something that when you dig into it is that surprising, even though it may seem surprising on its face. And so this is also an example where we had, brought different types of data together, claims and registry data. So we again had that deep clinical information on this coronary intervention cohort. And it was an example where now to look at the methods, where using double robust machine learning was actually the only technique that was able to find these heterogeneous effects. All the other methods did not. And we were able to reproduce this in a simulation study. So it provides evidence that these are not spurious results, that it really is that the signal is difficult to find, that by using a double robust method, so using information from the outcome mechanism and the treatment assignment mechanism with flexible machine learning is really what gave us the advantage here in order to find these treatment effects. And this paper is also available, freely available in Biometrics if you want to see the data analysis and the simulation studies that we designed. And so this leads us to have a lot of different types of questions about the potential implications for many different groups: patients, hospitals, manufacturers, and regulators. And I don't have all the questions on here, but just a few. How can this information be incorporated into the patient's decision-making process? Will hospitals reconsider their complex contracting with manufacturers to avoid poor performing devices? Should manufacturers consider pulling stents from the market? And how should regulators respond to post-market information that is not available at the time of device approval? And I was going to say I don't even know how recent it is, the pandemic, the time is passing in strange ways during the pandemic. I previously, at some point in time, gave a talk about this study at the FDA, at an FDA conference, to try to talk about some of these questions and get their input. But one other thing that I'll highlight, going back to generalizability, is that this study was conducted in a clinical registry in Massachusetts. There's no reason to think that this study would necessarily transport to other states or is broadly true of the entire United States. And so I look forward to potentially having opportunities to study this in other populations. So now in closing, I want to mention a key paper on examining racism in health services research, discipline self-critique. So I work in health services research, and I think it's really important that we all are thinking about and acknowledge the influence of white supremacist ideologies in health services research, in health policy. And so this paper is a very important read for all of us who are working in the space. If you are interested in some of the types of methods that I talked about today, machine learning and epidemiological methods in health services research, I wrote an overview paper about this in IJE. And then lastly, I want to close by positing a question that we should all be asking. Does your algorithm have a social impact statement? Who is responsible to users if they're harmed? Is it explainable to users? How accurate is it, and how are we defining accuracy? Is it auditable by a third party? This is incredibly important. A lot of times the algorithm itself will be proprietary or the data cannot be shared. And so building, again, in healthcare, we need to build systems such that somebody else, somebody who does not have a stake in the tool, is able to audit it. And then lastly, we discussed some of the issues around fairness. So I want to close with some acknowledgements to former and current trainees that I've worked with on many of these projects, and also acknowledge my funding, and then also highlight the Cite Black Women Collective founded by Kristen Smith, so that we can acknowledge and honor Black women's contributions and intellectual production. As academics, we really need to reflect on our citation practices and incorporate Black women in a central way. And I think in statistics, we really don't do enough of this, myself included, that we all need to be more thoughtful about this. And then, so I think that is my last slide, and thank you very much.
Thank you so much for a fantastic talk and great discussion. And thank you to everyone who has attended. So take care, everyone.
Thank
Bye-bye.
you. Bye.